So, Assalamu alaikum, good afternoon or good evening or good morning to wherever you are and joining us today for this Health and You Community Wellness Series session. I'm Dr. Sohaila Chima. I am an Assistant Dean for the Institute for Population Health and also an Associate Professor of Clinical Population Health Sciences here at Weill Cornell Medicine-Qatar. Just as a reminder, this is not a CME CPD activity. So this is geared towards the general public. And the overall goal of this series is really to create community awareness about health and disease. And the ultimate objective is really to enhance self-care, reduce suffering, and improve the quality of life and increase healthy longevity. Just some housekeeping, your cameras and microphones, they've been turned off. You can use the Q&A feature to type your questions or comments, but you can also use the chat feature. If you want to just put the comment or question in the chat, please do so. We are able to see that also. And questions, again, will be addressed at the end of the session. If you have any questions as the session is happening, you can go ahead and post them, but we will address them at the end. And I will be moderating the session today for the questions. So just as a reminder, again, this is not a CME CPD activity, so no certificates of attendance will be issued. So we come on to the session. Today's session is titled, Could Your Abdominal Pain Be Due to Irritable Bowel Syndrome? Our speaker for today is Dr. Mahmoud, and I am delighted to introduce Dr. Mahmoud. She's our Assistant Dean for Faculty Affairs, Director of the Students' Academic Advising, and Associate Professor of Teaching and Medicine at Weill Cornell Medicine-Qatar. Dr. Mahmoud is American board certified in internal medicine and geriatrics, and she practices as a consultant at Hamad Medical Corporation. She also is actively engaged in teaching medical students and residents. Dr. Mahmoud completed a Master of Education in Health Professions from Johns Hopkins University in 2017. She joined Weill Cornell Medicine-Qatar in 2006, where she was teaching first year, second year, and third year courses. She's a fellow at the American College of Physicians, and she served on a number of international and national Qatari research and organizational committees. She's also a scholar of Harvard Macy program. Dr. Mahmoud, a very, very warm welcome to you. Well, we look forward to your session, and over to you.
Thank you so much, Dr. Chima. It's always a pleasure to be with you in this community. And I'm glad to see you kept the flow going and you kept the people coming to your sessions. So
yes,
that's good. So today we'll talk about Irritable Bowel Syndrome, or IBS for abbreviation. You will hear me using them interchangeably. And the goal of the session is to go over the Irritable Bowel Syndrome in terms of what causing IBS, how patients present, and how we manage them. And we'll touch a little bit on the common causes of chronic pain or stomach pain or belly pain. And we'll leave plenty of time for question and answer. The topic is not big, so I will have plenty of time for question and answer that you may have. Is the sound okay? Can you hear me okay?
Yes, we can.
So I will start with a patient, and I want your attention because you're gonna diagnose this patient at the end of the session. And I will walk you through how us clinicians or physicians try to figure out the patient problem when they come to us. So this patient is Miss F. She's 35 years old woman, referred for chronic stomach pain. And by chronic means long time, more than 2 months up to years. So she has this pain for 2 years. And this is usually the complaint I see in my clinic. For how long you have this pain? For a long time, 1 year, 2 years, long time. It's not something that happened in an hour or 1 day or 2 days or a week. The nature of the pain is cramping. It comes and goes. She has bowel movement every 2 to 3 days and is hard stool, so she has constipation and often sees mucus on her stool with no change of color. She denied weight loss. These are common questions we ask, and no bleeding in her stool. Otherwise healthy. She doesn't have any other medical problem. So the question for us, could this be IBS or irritable bowel syndrome? And before we go there, when we hear complaint about stomach pain or pain in the stomach, we try to figure out as physician, where is the pain located? So this is a diagram of what is in our gastrointestinal system, starting with the esophagus, followed by the stomach, and then the small bowel, and then the large bowel. And also we have the pancreas, who secretes enzymes and hormones to control the digestion and also control sugar in the blood. And the liver, who also helps in metabolism of food that we eat. Behind this gastrointestinal tract, we have the kidneys in the second diagram. You see the kidneys, and we also have the ureters and the bladders. And for women, we have more organs like the ovaries, the uterus, and prostate, for example, also in men. So when we have a complaint, our job in the clinic, and because I do mainly outpatient practice, and most chronic pain come to the clinic, not to the acute setting, not to the hospital. So we try to figure out what pathology could it be and where is it? So is the problem in the stomach? Is the problem in the liver? Is the problem in the small bowel, pancreas, large bowel, kidneys, ureter? This is how we try to function. When we try to identify the organ, we also dig deeper to know the pathology of the disease. Is it inflammation? Is it obstruction? Is it something else? And by asking more questions in the history. Some disorders, we cannot characterize it. We cannot identify a specific organ or a specific pathology. And this is what we call functional. And this is a new terminology, functional gastrointestinal disorders. So these disorders usually characterized by chronic symptoms. It could be abdominal pain, it could be difficulty swallowing, diarrhea, constipation, bloating, in the absence of demonstrable pathology of conventional testing. So there is no pathology identified in the stomach or in the colon, small colon, pancreas. We cannot identify pathology in this organ. This is what we call functional. And there are many functional GI disorders in adults, like 33 disorders identified by the society. And IBS, which is irritable bowel syndrome, is the most common. It's very, very common that we see in clinic. So, for example, if I see 10 new patients in my clinic a day, I would say roughly maybe 5 or 6 of them, they will come with chronic abdominal pain. And most of the time, the diagnosis is IBS. So what are the main symptoms or how people present? Is belly pain, as I said, usually cramping, and is usually for a long time. And it has also change in bowel motions. Either they have constipation, or they have diarrhea, or they have alternating diarrhea and constipation. So sometimes they have constipation, sometimes they have diarrhea. These are the major symptoms. Other symptoms that people usually complain about: bloating, so they feel their abdomen is distended, belching also. They feel gases in their stomach. Sometimes they see mucus in bowel movements, but you don't have to have all these symptoms to be diagnosed as IBS. The major one is pain and change in bowel motion. Okay. In the US, estimated that 10 to 20% of people have IBS. Globally, 11%. But as I said, I don't have statistics here in Qatar. I cannot find, but it's very common that we see in the clinic. So what causes IBS? Why people get IBS? Although it's been a diagnosis for a long time, many years, but till now we don't know why people get IBS. It's unknown. It's thought to be a result of multiple factors or theories, which I explain here in this diagram. So it could be, one theory says visceral hypersensitivity. So whatever we have, visceral means the organs we have in our stomach. It could be hypersensitivity to whatever stimulations they get. It could be motility disturbance. So we know the stomach, the GI, stomach and bowel, they contract to push food down and helps also in digestion. If they get any disturbance in motility, they may cause strong contractions causing the pain. There is theory about inflammation. Some people, after they get severe infection due to bacteria, severe bacteria like salmonella, they may develop IBS after inflammation. There is also theory about bacterial overgrowth. Normally, we have normal bacteria in our bowel, but if it becomes too much, it could be the cause for IBS. And also there is a theory, and this is new area for research, alteration in fecal flora. The microbiota in the stool is different. And that's what the study was found, that they tested the stool in people with IBS and normal people, and they found differences. And when they introduce the stool from people with IBS to animals that they don't have any flora, they develop symptoms of IBS. But this is not confirmed. The general impression that most of the time is more than one factor affecting the GI and causing the IBS. There is definitely genetic factors. We don't identify specific mutation or specific genes that related to IBS, but we know it runs in family. So one of the questions we ask in the clinic, do you have anyone in your family diagnosed with IBS? And also there are some psychosocial factors, stress and anxiety, and there is also some studies on abuse, either bullying in school or any kind of abuse is also predispose people to IBS. So, and now the new terminology for this is disorder of brain and gut axis. So what it means is there is increased intestinal sensitivity to normal sensation in basic words. This is what it means. And as you know, I have this diagram here on the right that the nerves, the brain control all our nerves and our stimulation in the body. So there are nerves come from the brains, there are nerves come from the spinal cord here to the to the GI organs, the gastrointestinal organs. So even we know there is probably increase in sensitivity of these stimulations in people with IBS, but it's also we are not sure whether the problem is it the local nerves in the GI, is it the stomach and the bowel problem, or is it regulated or modulated by the brain, or is it just hyperalgesia to these organs of whatever stimuli they have, or is it coming from increased spinal cord excitability? And again, most people believe it's more than one thing. It could be two, it could be the brain and the GI, or it could be hyperalgesia and the brain. So we are not sure why people develop IBS. So this is, again, a review of what I just said. So in the brain, there are stimulation, and also there are some psychological factors like people who have an anxiety, depression, or any psychiatric condition. And they have also the excitability of the brains. And they have also some predisposing factors like genetics and sex. For example, we know women are more prone to IBS than men. Any social trauma or abuse, even from school time. This is all contribute to the physiology of the GI or the brain-gut axis, and it causes disturbance in motility and sensation, in alteration of microbiota in the gut. And this is, of course, causing the functional GI symptoms or functional disorders that I mentioned earlier. And at the end of the day, this is definitely affect people quality of life. So almost everybody come to the clinic, they are frustrated because when they come to Hamid, they already seen many doctors outside, primary care, health center, and the final thing they get referred to Hamid. And I'm a general internist. I run general internal medicine clinic. And even if I cannot help them to the maximum or become satisfied, I can refer them further to the gastrointestinal specialist for further testing. So it's frustrating to patients. The diagnosis itself is frustrating. Almost everybody they come, they fed up of their complaints and the medications they tried. So it's not happy, it's not a good disease to have. So again, as doctors, we don't have tests for IBS as a clinical diagnosis. So the typical thing happen in the clinic, the doctor ask you about questions about the pain and the severity and how affecting your life, the nature of the pain, how often you get the pain, is the pain related to any food, related to anything, stress, whatever. And they ask about other symptoms for gastrointestinal, like constipation, diarrhea, nausea, vomiting, reflux, if you have any reflux, any change in bowel motion, any pain goes anywhere. So, and they also try to rule out other causes, for example, gallbladder diseases. Gallbladder, I forgot to mention at the beginning, but it's also a very common cause of belly pain. So we have criteria that we use, and I will share it in the next slide. The test we do here is to rule out other possible diagnoses. For example, in this part of the world and in developing countries, Helicobacter pylori infection causing infection in the stomach and the duodenum, which is the first part of the small bowel, is very common. So I usually make sure that the patient doesn't have Helicobacter pylori before I can say this is most likely IBS. And because it's very common and most of the time is not one of the routine tests we do, I want to make sure that the patient doesn't have that. And it's easy test to do. We just test the stool for H. pylori antigen and we get the result. Make sure that you are not taking stomach acid medications like PPI, like Nexium and Parit and all that. You have to stop that 2 weeks before you give the test because it affects the test. Giardia is also very common here, and we send also the stool for ova and parasite, and we do another blood test. And calprotectin is inflammatory marker also in the stool. It indicates maybe the problem is not IBS, the problem might be inflammatory bowel disease. Those are Crohn's disease and ulcerative colitis. So, and we also do celiac serology. Celiac disease is not common in Doha, and I've been screening people for celiac disease. I haven't seen any positive case. It's more common in Northern European Ireland countries. And CRP also is a test for inflammation. If it's high, it tells you there is some inflammation in your body somehow, and this is probably not IBS, because IBS shouldn't have increased CRP. So we do this test in addition to routine tests, for example, CBC and all that. But these tests are specific when we suspect IBS, just to rule out other diagnoses. We want to make sure this is not H. pylori, this is not Giardia, this is not inflammatory bowel disease, this is not celiac disease. So this is the criteria. There are many criteria, as I said in my previous slide, but ROM4 criteria is the most common used. And this is the minimum frequency of pain. So you need pain 1 day a week in the last 3 months and associated with 2 or more of the following. As I said, related to defecation or bowel motion, and also associated with the change in frequency of stool. Is the frequency every 5 days, every 7 days, or if the frequency is 2 times or 3 times a day? And also the form of the stool. Is it watery? Is it hard stool? Because this also can identify diarrhea and constipation based on that. So what doesn't go with IBS? If one of a sudden somebody started developing symptoms after age 50. Some people, they do have mild symptoms, but they try to ignore it, or they have symptoms before 50, but they try to always relate it to food. It's IBS at the end of the day, but they will say, because I ate this, I had this pain. But the diagnosis of IBS never labeled or never told to them. So this is still can be IBS, but if you don't have any abdominal pain all your life, and just after age 50, you started having pain, then this is something that doesn't go with IBS. Bleeding, if you see bleeding per rectum. It could be, for example, simple thing like hemorrhoids, but it could be also more dangerous thing like cancer, or not dangerous, but more serious diagnosis like cancer. You could have both. You can have, for example, IBS and hemorrhoids, of course, because one of the reasons is also constipation, and people strain to defecate. You can develop hemorrhoids. Unintentional weight loss. IBS by itself, it should not cause weight loss. It's one of the criteria. You should not have weight loss. And here people spend money and energy and everything to lose weight, and not easy to lose weight. So if one of a sudden you are not doing anything and you're losing weight, this is something needs more investigation. If you have daily multiple loose bowel motion or night diarrhea, it also doesn't go with IBS. If you have difficulty swallowing, what we call dysphagia, if you have problem with the swallowing, this is not IBS. Anemia usually indicates there is some bleeding going in your GI. If we see blood, it's probably fresh blood coming from the lower side of the GI. That's why we see it fresh. But if sometimes the change of the color of the stool to black, for example, it could be bleeding happening in the stomach or in the esophagus up, and it get digested with food and just change the color of the stool. You will not see blood. So when we see anemia, it also raises suspicion for something else, probably not IBS. If you see progressive pain, like this week the pain is once a week, and next week is every day. So if you see the pain is progressive in terms of frequency, but also in terms of severity, this is something you want to check. And if there is family history of inflammatory bowel disease, those are Crohn's and ulcerative colitis. Also, this is something warrant further investigation, just to make sure it's not inflammatory bowel disease. This is not fun. So we ask people to make a diary. So after we take history, physical exam, we do blood test or stool test to think about other diagnoses. We ask them also to make diary for their stool for 2 weeks. 2 weeks, I guess, is enough because it's not fun. We don't want you to look at your stool for more than that. And you tell us what is the type of your stool. This is in Google, in internet. If you don't have to memorize it, but if you want, you can get even the shape of the stool from the internet. What is type 1 look like? What is type 2 look like? So the normal variance from 3 to 5, number 1 or 2 goes with constipation, and 6 and 7 goes with diarrhea. And doctors usually, they have formula how to diagnose you, which is the most common subtypes for you. Is it mostly constipation, or is it mostly diarrhea, or mix? So there is percentage. If it's more than 25%, I don't want to go in details, but we have a mechanism to decide which IBS that the patient has. We also ask for food diary. So every time the patient get pain, they should document exactly what they ate that day. And this is what I tell my patients. I said the treatment depends on you. You have to be careful what you eat. And every time you get pain, write everything. Write even the snacks, smoothies, everything you eat that day, you have to write it down. And 2 to 4 weeks, you can figure out if there is pattern that trigger the pain. So once we have a diagnosis, the next thing is management. So we have general recommendations, and because this is a webinar hosted by Population Health, I'm sure they will be happy to see lifestyle. They have a big course they run here about lifestyle. So lifestyle modifications, and I'm sure whoever you see, whether it's internal medicine or neurology or heart doctor or surgeon, lifestyle is always recommended because it helps. And it is evidence-based. So we have studies that showed people who change their lifestyle, they have less pain and less symptoms from IBS. So what is recommended is you do 3 to 5 times per week. It improves symptoms, whatever you like, just walking, swimming, whatever you like to do as exercise. Yoga, for example, could be helpful because it relaxes you. Sleep hygiene is extremely important. People here, so the simple thing I tell my patients is if they have sleep disturbance, if they don't have sleep disturbance and they sleep good 8 hours, then you don't have to do much. But if they have a sleep disturbance, they have to work on sleep hygiene. So for example, I say no caffeine, coffee, tea, anything that has caffeine, sodas, cola, something like that. After 4 or 5 p.m. It depends on what time they go to bed, but better to limit the caffeine. They should keep their routine even over the weekend. If they sleep every day at 8 or 9, they should keep it even during the weekend. And they can use also melatonin if they have, if the sleep hygiene doesn't work. Melatonin is over the counter and is proved to work in patients with sleep disturbance and IBS. There is also, I don't want to forget, sleep apnea. So people who snores when they sleep, usually overweight or obese, and they have short neck. These people also, they don't sleep well during the night, and during the daytime, they're more sleepy. So I will send them for a sleep study to diagnose sleep apnea if it's there, because we have a treatment for it. They can get machine and they can sleep on the machine at home. And brain gut behavior therapy. I don't know if this is available everywhere, but also we know it works. So, and the first two basically focus on relaxing the muscle and make people in control of their body. So they teach you certain mechanism, how to shift your thinking, for example, from the pain that you feel in your stomach to something else, breathing or something else that distract you from thinking about your pain. And it also helps. So meditation, if you have app, you can use app at home if you don't have a provider for this therapy. Cognitive behavioral therapy is also important. It's done by professional people. And the same thing, they make you aware of the symptoms and how to overcome it. These are especially important for people who don't want to try medications. So some people come and they say, I don't want to take any medications. So for those lifestyle modifications, they should try it, and anybody else should try it before we start the medication. The non-drug approach, so dietary elimination. So after they figure out their diary, what triggered their pain, then they have to eliminate whatever. So I tell my patients, everybody's different. Some people, for example, they're hypersensitive to tomatoes. Other people, they eat it and they don't have any problem with it. But we know there are general things that affect everyone. And those are spicy food. You know, in this part of the world, we like spices and we like hot, spicy hot food. So they should eliminate that, especially pepper. Fatty food, anything cooked in deep oil and they have lots of fat is fatty food. We should avoid it. Carbonated or fizzy drinks, sodas, champagne, all that, not good for your stomach. Cut down on dairy products. And dairy products, there are some we know like milk, yogurt, cheese, but also don't forget ice cream, smoothies, creamers. These are all has lactose and can affect the GI symptoms. Also, it's important to record what you did and how you felt that time, just to see if there is any psychosocial factor to your pain. If you feel stressed, or of course, it's very hard not to feel stressed these days, right? But not too much stress, and how to control it is more important. So there is also, if somebody has constipation, we recommend high fiber diet. It works for some, It may cause more gases or more bloating, but I ask people to try it. Usually brown food like brown bread, brown rice, they have more fiber. You can also buy fiber from the pharmacy and add it to your food. There's something called low FODMAP diet, and FODMAP stands for fermentable oligodisaccharides and polys. And these are big lists. Again, you can Google it from the internet and see what are the food that are low in FODMAP that you're supposed to eat. Here is a short list of eggs and meat, but no sauces, rice, almond milk, grains, vegetables, some vegetables, and some fruits. This is exhausting list, and again, I am not expecting you to memorize all, but you can Google it in the internet, and you can see the food that can suit your style and the food that you like. This is what you're supposed to be eating. I also advise against the food that cause gases and make people bloated, and those like beans. Here in this part of the world, ful, falafel, basolia, like beans, white beans, red beans, and some vegetables also can cause gas, like cabbage, broccoli, cauliflower. These are my favorite vegetables, and Brussels. So it depends on the symptoms that the patient has. After you, of course, decide on what trigger your pain from food, you try to eliminate them. If it doesn't work, then we start medications. And some people, and I usually say, give yourself just a time, like 1 month. Stick to whatever food that eliminate all the food that trigger your pain and see how you feel. And if people are adherent, most of the time that will work. And I see some people really religious about what they eat and what they cannot eat. And I see some people, they cannot just keep because they eat either junk food, especially younger generation. They want to eat from outside, and junk food is, or fast food, is full of fats. So we can give also medications to help. And number one medication we give for pain, if the patient has pain. We give anticholinergics, and these usually help the muscle relax, the muscle of the GI relax. And because, the contractions, the pain happen when you have contraction, you have cramping. So this muscle relax the pain. And usually we ask people to take it before food. So mebeverine is famous here in Qatar. The trade name, one of the trade names is Daspetalin. And we can also give antidepressants, the tricyclic antidepressant in a small doses. And just not yesterday, last week, one of the patients came very angry because her doctor gave her nortriptyline, and she went and read the pamphlet, and she came very angry. He gave me medication for depression. I don't have depression, and it has many side effects and all that. So it's not her fault, of course. The doctor is supposed to explain to her, although these medications called antidepressants, they are not given for depression. We are still treating your pain, your problem in the stomach. Because for depression, we give very high dose. But for abdominal pain or IBS, we give a small dose. And these medications work. So yes, they have side effects, but everything has side effects. Even Panadol, we take like every day for whatever we have. It has side effects, right? But most of the time you have to weigh the benefits, the pros and cons. Why you should tolerate the pain if you have medication that can improve the pain. And of course, if you have any side effects that you don't like it, we can always stop. But I think it's worthwhile trying one of these medication for some time and see if it helps the pain. Again, the dose is very small than the dose we give for depression. And these medications are being here for long time. It's not new medication. So it's well studied, and we know they work. This is for the pain. If the person has constipation that we want to treat, of course. So again, dietary modification. So we ask them to eat more fiber food, hydration. I notice when I ask people, do you drink enough water? Yes, I drink 2 bottles of water. 2 bottles of water, how much? 600 a day is not enough, especially in hot weather now we are experiencing. And also in cold weather, because in cold weather, people don't feel thirsty. And when they feel thirsty, it means their body, and they forget to drink. When they feel thirsty, it means that their body is bugging them to drink, which is not good. We're supposed to be drinking all the time. So I say at least 2 liters a day hydration, because we need water to push the food down, right? If you eat and you don't drink water, the food will stuck somewhere, will not go down. So hydration is extremely important. Make sure you drink enough water throughout the day. If just one of a sudden you remember that, oh, I didn't drink any water today, and you drank 2 bottles of water, like 1 liter or 700 liters, it will not stay in your body, because your body doesn't need all this amount at this time. It will go to the urine, right? So you're gonna be that. So it has to be every hour, every 2 hours, all day long, and don't wait till you feel thirsty. And high fiber diet is important. There is medication, polyethylene glycol. Most people start with that, and we start with in Hamad is available in Hamad in our hospital here, and in many parts of the world is over the counter. You can buy it from the pharmacy. They have different name, and you can start with once a day, and every 3 days, if you don't have bowel movement, you can increase it up to 3 times a day. Okay, again, tricyclic antidepressant, nortriptyline and amitriptyline will work. If the patient need colonoscopy, and we don't do it only for constipation alone, if they don't have the alarming signs or the alarming symptoms that I mentioned earlier, like weight loss and blood, we don't do colonoscopy, which is a tube that they put through the rectum to see the whole colon, the large colon. We don't do it unless the patient did not have any screening. So usually from 47, 48, we start screening people, definitely from 50. If they don't have cancer of the gastrointestinal tract in their family, it's recommended to do colonoscopy every 10 years, or there is a special test that they do here in health centers every 5 years. Either one is a screening for colon cancer. So if the patient is above 50 and they had constipation and they never had any colonoscopy done as a screening, I usually send them for colonoscopy for screening. And if the constipation is severe, which sometimes the case, sometimes I give everything. I give polyethylene glycol. I add Igulax, which is another laxative, and nothing work. I send them for more testing, because sometimes there is the brain and the GI don't work properly. So there is unintentional disorganization or coordination between the brain and the GI. So this is need investigation, and it needs special treatment if there is a problem. Psyllium, our Igulax, is also over the counter. We give it. It's not very good laxative, but I add it if somebody says I use polyethylene glycol, but I still feel unsatisfied. I feel still I have stool in my rectum, so we add Igulax. If patient has hemorrhoids, because we don't want them to strain, we can give Igulax. Again, it causes bloating, so we advise them to take it at night. If the problem is diarrhea, again, dietary modification, especially dairy products, because these causes diarrhea for sure. So eliminate dairy products completely. And sometimes because maybe somebody started on medications that known to cause diarrhea. For example, the diabetes medication, metformin, is a very common side effects from metformin is diarrhea, especially if they started recently, or other medications. So we always go over the medication the patient is taking, and we think of other causes. Maybe it's not from IBS, or maybe this thing contributing to patient having more diarrhea, the medication that recently started. We have medication like lopramide, especially for social reason, for somebody going for a function, we don't want them to have these symptoms. We give them loperamide. They have to take it also before a meal. And if loperamide doesn't work, dietary modification and loperamide, they don't work, we can add something called cholestyramine, especially for people who remove the gallbladder. You know, most people, they have this pain for a long time, and at one point, correctly or incorrectly, somebody blamed the gallbladder and it's taken out, and they still have the same pain. Maybe the IBS is getting worse. So we give the bile salts that normally produced by the gallbladder, but because the gallbladder is no longer there, this is a replacement. We give it also a try to see if it improves their diarrhea if they have gallbladder surgery. If the patient is alternating, the best thing, alternating symptoms, diarrhea, constipation, so the best thing to do is to do lifestyle modification, and we ask which one the patient input is important here. Which one is bothering the patient more? Is it the constipation or is it the diarrhea? And we try to control these symptoms. But again, very important to be active and eliminate the food that known to cause problem with GI. And then we treat if this diarrhea dominant or constipation dominant. And sometimes people change. So I put it here in subtypes: constipation dominant, diarrhea dominant, all alternating, or unspecified. There is also one called unspecified. But sometimes over the years, the symptoms change. They may start with constipation only, and then after 1 year or 2 years become diarrhea or become alternating. So it's very important for us also to check in frequently every time we follow the patients. Is the symptoms the same? Is there any change in their symptoms? And we treat accordingly. Many people use biotics, prebiotics, probiotics, and biotic, and it's not part of the official recommendation to treat probiotics because the data from these are very heterogeneous. So some people are pro and some people are against probiotics. But probiotics has low rate of adverse effects, and if the patient come to me, it's expensive, so I don't recommend it. But if the patient come and is taking probiotics already, and if they feel it helps them, I will continue it. I will not say stop. We still don't have enough data for pro or synbiotic, although synbiotic seems to be promising. So we may see something in the coming future. Peppermint oil is good for the pain. So I guess you can get it from grocery stores. And people can try it. I don't mind. Many studies showed that it works. The enteric coated peppermint oil. Stress management, if we can, we all need the stress management, right? But especially if you have IBS or functional GI symptoms. And there are many ways you can seek professional advice, or you can use app stress management, or you can try activities like yoga, meditation. But we know, for example, exercise is a natural antidepressant, because when you walk, when you exercise, your body secrete hormones that do the same thing as antidepressant medication. Alternative medicine. So many people, my mom, my grandmother, they always say fennel seeds, chamomile tea. They are not proven to work, but they are harmless. So if for some people they work, okay, they can use it. But generally, the studies did not prove that they work. So my final question to you: does Miss F has IBS? I would say most likely, yes. She has chronic pain. It's typical, is more than the criteria once per week for 3 months, has going on for years, right? And she has constipation, and she has mucus, which is not necessarily that is there, but she fulfilled the criteria for IBS. So this is all what I have to say. Happy to take any questions, and thank you for listening and staying till the end.
Great. So thank you so much, Dr. Mahmoud, for that. It was very, very enlightening. I think it is a common problem So I think it's good to get clarification on a lot of the points that you've mentioned. So I'm just going to start with some of the questions. IBS, I mean, we can talk a little bit more about maybe some other chronic pain conditions, which you maybe commonly see. But IBS, do you see it more commonly in men or women, or is it seen in both, sexes? And I know you mentioned that above 50, it's probably unlikely that it's IBS. So under 50, but is there more sort of an age where we see that, teenagers or 20 to 30s, 30, or is there no specific age or gender?
So usually is disease of younger people
Okay.
and is more common in women than in men.
Okay. Okay.
Uh, Globally, the frequency, as I mentioned, is like 11%, and I couldn't find any statistics here in Qatar. Maybe some it's not
Mhm.
looked at yet. That is very common. Just from going to the clinic every week, I can see many patients has IBS. I think the problem with age, some people have symptoms, but they don't go to doctors. They are not diagnosed or misdiagnosed. So
Right.
even if I see somebody in their 50s, it doesn't mean that they have this problem just to start it now. I'm
Sure.
sure when I dig deeper in the history and question them, most of the time they have these problems for years. But
Right.
they use alternative medicine, over-the-counter medication. They blame this food or that, but the
Yeah.
label of IBS is never given to them.
Mhm.
So yeah, if it's more age, I dig deeper, try to figure out is this undiagnosed problem that
Sure.
came to this, or this is a different problem that I have to investigate.
Right. Excellent. Thank you. So, Dr. May, let me ask you this. I mean, of course, this is a chronic problem. How would you suggest that, we better support patients dealing with chronic pain and, IBS? Are there any tips to, help support them better, maybe for caregivers or people living in their family?
So, yeah, and that's nice to see people want to support their relatives or their friends. So it's not different. So helping them decide about the triggers, I think, is crucial because unless you know what trigger the pain, you cannot treat it. You cannot eliminate that from your diet, right? And as I said, everybody is different. There is
Right.
no food that we can say this is not good. We know for
Sure.
sure, for example, most people struggle with fatty food and spicy food.
Right.
And if the symptoms more towards diarrhea or bloating, maybe there is lactose intolerance. So the first thing I would say, there's stepwise approach to figure out
Element.
what's the
Right.
problem. After you do the diary, for example, I would say the first 2 weeks eliminate any fat and spicy food from your diet and see. If there is no improvement or mild improvement, next step, try to eliminate all dairy products from your food. Don't eat dairy products. And then they will see in a month of time. With the
Sure.
diary they make and with the stepwise approach to eliminate food, we may reach to a list of certain food that they have to avoid. And try to eat the food that I showed in the list food map.
Got
It's a long list, and they can get many things from the
Sure.
list.
Great. And thank you so much, Dr. May, for mentioning, the lifestyle, how lifestyle modifications can really work and benefit, in these patients. So people listen to Dr. Mahmoud, go go with lifestyle modifications, wherever you can, be a little bit more active, focus on the nutrition, the food that you're eating, reduce the stresses in your life, and so on. So it will help you with overall health also. So, Dr. Mahmood, let me ask you again about IBS. I know you alluded to, of course, lifestyle modification, and then that there are some treatments which are also available. So, how effective really are these treatments in managing IBS? I mean, how do people sort of benefit from them?
Again, it's different, right? So lifestyle modifications work. It helps most people, but it
Right.
will not eliminate the symptoms, right? So people add again food elimination.
Right.
And this is also depends on the person because we don't know what is the problem. We don't know the underlying disease, right? So it's hard to target the treatment if you don't know what causing it. And it's different from person to person. For example, if you eliminate lactose, it may
Mhm.
help 30% of the patients, but not everyone.
Okay, sure.
Okay, so if you don't feel better when you eliminate lactose, first you have to make sure because sometimes we don't recognize smoothie or ice cream or these are lactose. These are lactose. You can substitute your milk with rice milk or soy milk better
Right.
or almond milk better than the milk we drink. If it doesn't work for you, it's not the end of the world. We can try something else. Try whatever trigger your food. So uh, we support the patient till the end. We feel that they have pain. We acknowledge the pain. Yes, it's pain. It's real. It's not something they imagine. It's not something they think they have. And we try to support them. So it's multiple approach and very patient dependent. It's not one prescription for everyone. Medication, just last week, yesterday, I had a patient who was taking mebaverine. She said it's not helping, so I try something else. Some people say, for example, Movicol, which is is a protein, the laxative, it doesn't work. I can add something else if they don't feel completely satisfied. And
Mhm.
there are some medications even stronger than this. But before I go to stronger medications, there is a policy, it has to be written by specialists. I have to make think about something else. Is there something else going on that I missed? For example, the motility study that I can send them for motility study and figure out because the treatment is completely different. It's biofeedback training that can help them. And if my regular medications don't help, I refer them to the specialist for more aggressive medications.
Sure. Thank you, Dr. Mahmoud, for that. So we have a question about, is lactoferrin in stool have any role in initial workup to differentiate between IBS and IBD?
What is that? The stool?
Lactoferrin in stool.
Um, I believe is if you suspect something like malabsorption, it may help, and this is completely different. So with malabsorption, usually there is continuous diarrhea, there is weight loss. It's different from. So there are some tests you order it only when you suspect if you have high suspicion for a diagnosis because if you order it and then it's positive, you cannot interpret it because we have to deal with the person, not with the lab.
Right.
And this is one of it. So if you really have high suspicion for malabsorption or something related to pancreas, you can order medication. We order more likely calprotectin, which is specific for IBD. So if it's higher than the usual, the suspicion for IBD is higher.
Mhm. Okay, thank you so much. There's another question about, is there any cardiac manifestation of irritable bowel syndrome, especially in
Cardiac,
cardiac manifestation?
I don't believe so, but I think if you have bloating, that your stomach become bigger, it may affect the heart, and you may feel, for example, short of breath or palpitations if it's pushing on the heart. But
Right,
as the symptoms for IBS, I don't think so. If
right.
patient has an anxiety also, it may present with tachycardia or panic attack or something like that. It may be related, but no direct association.
Oh, director. So great. Thank you. So also, Dr. May, you alluded, when that for elimination, we try and eliminate all dairy products. Does that include yogurt, kefir? These have live bacteria. So would that also be included in the dairy products, or is it otherwise?
I would say yes. Initially, eliminate all dairy products. There are some people who say hard cheese is better. I would say initially eliminate all dairy products and see if you feel better, you can reintroduce one by one. You can
Right.
reintroduce hard cheese, whatever you think is not related, and see how it works. If
Mm-hmm.
it affect you again, it brought your symptoms again, eliminate it forever.
Mm-hmm.
Yeah. So I think the treatment is mainly on the patient, of the doctor.
Yeah, sure. Okay, so we have another question about, I think they're asking why difficulty swallowing doesn't go with IBS. I don't know if you have a reasoning for that. Why is that not?
Difficulty swallowing or dysphagia, we
Hmm.
afraid that it could be from structural reason. So something blocking the esophagus. So this is a disorder of the esophagus, which is the first part of the GI.
Right,
There
right.
is functional dysphagia also,
Yeah.
but this is not in the stomach. This is in the they feel it in the chest, in the esophagus.
Okay.
Okay, so if patient has dysphagia, we want to make sure it's not there is no obstruction. We most
Absolutely.
likely will do endoscopy. We send them for endoscopy to rule out structural reason for that. And then if it's negative, they might have also functional dysphagia, which is one of the functional disorders in the GI, but it's not IBS.
Okay. So, so I think we have a question related about probiotics, but they're asking in cases of SIBO, small intestinal bacterial overgrowth, is it beneficial to take probiotics in cases of SIBO, small intestinal bacteria?
Yeah, as I said, they are expensive, first of all. Second,
Yes.
they are not in the guidelines yet. So I cannot recommend it to
The
patients
standard
to
of care,
try.
it's not there.
And
Right.
the studies are very heterogeneous. There are some studies says yes, they are good, and some studies say there is no benefit compared to placebo, of course. But if the patient can afford it and taking it and feels they help, yeah, why not? I don't take it away. I don't say don't take it.
Yes, absolutely.
Since biotic, I think there are many
Yes.
research going now, and I think it's promising. Maybe it will be better than probiotics.
Okay, let's hope for that, and it can help a lot of patients if it can. So I'm going to just end with one last question, Dr. May. We are living in lives, which are very, very busy. We everybody is very stressed out now. We even hear of young children, being stressed, which we never heard of, many years ago when we were children. Again, you did allude to, bullying, and of course we have social media now, and all of that, and then of course, younger adults as they're stepping into the real life, the stresses of life, can become hard. What is your advice, to maybe parents for the younger generation, and for young adults? How can we sort of manage stress and manage some of these issues, the social issues, which are happening in our lives? What advice would you give to them?
It's a $1 million question, right? I think, and you had session about social media and children and
Yes,
stress,
yes,
right?
that went very
So
well.
yeah, so I would say I think once in a while stress. For example, if I'm giving this talk, although
Yes.
my Zoom is maybe less stressful than in person. I'm sitting in my office, same environment, so I'm less stressed.
Yes,
It's a stressful situation. So it's
sure.
okay to feel a little bit stress, or you go into exam or whatever something is stressful conditions. I think it's okay to feel a little bit stressed, but we don't want it to be all the time.
Yes.
What I would say, people have to learn mechanism to control their stress.
Mhm.
And this is different. It's outside of my specialty. I
Yes.
personally use app that at night, if I have difficulty sleeping or I'm stressed about something, I just follow whatever they have in the app, and it decreases stress.
Mhm.
Some people use professional help. I think also is a big stigma in this part of the world to look for counseling. If
Mhm.
you feel your son or daughter have an anxiety or they struggle with an anxiety, seek professional counseling. I think it will help. It doesn't have to be medications. Most people don't like medications, but it could be therapy, cognitive therapy,
Yes.
behavioral therapy, something that teach us and teach our kids how to control stress. So I think it's gonna happen. It's predictable, but I think the most important thing is to learn how to cope with the stress. Of course, social
Yes.
media. If you can limit the time, if you can make your kids listen to you, to whatever pediatric association recommend, half an hour or 1 hour a day, that's good. I don't know how feasible it is, try to get them more engaged in activities, especially teenagers and young adults. Do sports, basketball, football, all these kind of sports. It helps in decreasing stress, decreasing anxiety, and also teach them other skills, teamwork and other things, and put them in a healthy shape. So that's what I can say.
Yes. I think that's great advice, and really, a positive note to end this session on. So thank you so much, Dr. Mahmoud, for taking time out from your very busy schedule. We really appreciate it, and I'm sure our participants have benefited from the session today. So thank you, and
Thank
thank you
you
to
for
all
the
our
opportunity.
participants. Yeah, thank you to all our participants also who were able to join us. We have more than 100 people who've joined us today, so that's wonderful. And inshallah, we hope to see you at the next session, which will be in May. So thank you and bye-bye for now. Assalamu alaikum.
Bye bye.
Bye.